Hi, everyone. My name is Lauren Ruas. I'm a neonatologist from Winnie Palmer in Florida. We're going to give it just a couple more minutes because I see that lots of attendings are joining. So we'll probably start at about 2 past the hour. All right, well, it looks like we're still having some other attendings join, but I want us to go ahead and get started with the introductions. My name is Lauren Ruas. I'm a neonatologist from Winnie Palmer in Florida, and I thank all of you for coming to our exciting talk today. I would like to remind everybody that this talk is recorded and will be available on the Neonatal Hemodynamics Research Center YouTube page, free for anyone to view. Please put your questions in the Q&A. Whatever questions we are not able to answer, we will send them out via Twitter with the appropriate responses from the people that you are asking them to. And now I'd like to introduce our moderators, Dr. Shazia Bambal. She is a neonatologist and cardiologist from Emory, and Dr. Danny Weiss, who's a neonatologist and targeted neonatal echo specialist from Sunnybrook in Canada. Thank you.
Thank you, Lauren, for having us on today. And Danny and I are excited to be moderating what is sure to be a stimulating session on CDH phenotypes. And I'm thrilled to be doing the introductions, both of our speaker and our panelists. So our speaker today is Dr. Gabriel Altit, who's really a phenom in the world of neonatal hemodynamics. And if I had a fraction of his energy, I really think of things I could accomplish. Dr. Altit did his pediatric and neonatology training at University of Montreal and additional training in echo scanning at McGill, as well as postdoctoral research training in the Peds Echo Lab at Stanford. He is currently a neonatologist at Montreal Children's Hospital, where he created the website and app NeoCardio Lab and launched a neonatal hemodynamics clinical research fellowship at McGill. Joining him today on our webinar are an esteemed group of panelists. Dr. Mira Fraga is attending neonatologist at Children's Hospital of Philadelphia, an associate professor of pediatrics at University of Philadelphia. She's developed the neonatal point-of-care ultrasound program in the NICU at Children's Hospital of Philadelphia and trains attending neonatologists and fellows in diagnostic procedural bedside ultrasound applications, as well as takes care of a number of patients with congenital diaphragmatic hernia. Dr. Amish Jain works as a staff neonatologist and clinician scientist at the Sinai Health Systems Tannenbaum Lunenfeld Research Institute, and as an associate professor of pediatrics in the University of Toronto, where he also completed a PhD in cardiovascular physiology. He's site director of the targeted neonatal program, ECHO program at Mount Sinai, and is an avid researcher with multiple grants, including the Heart and Stroke Foundation of Canada Clinician Scientist Phase 2 Award for his research program entitled Improving Management of Pulmonary Hypertension and Right Heart Function in Neonates. And finally, Dr. Florian Kimpfmuller is currently working as an attending physician at the Department of Neonatology and Pediatric Intensive Care in Germany, where he's an associate professor of pediatrics. He completed a research fellowship in radiology at Harvard Medical School in Boston and is chairman of the Division of Congenital Malformation at the Center of Rare Diseases in Bonn. He's leader of the CDH research group at Bonn and member of the CDH Euro Consortium. So with that, thank you for all the panelists, and I'll introduce Dr. Altit to discuss CDH phenotypes.
Thank you so much. And I really want to take the time to thank the organizing committee for putting together these really great sessions. I know there is so much organization that goes behind this, and I find that it's a unique opportunity for everyone to share their experience, their expertise, and really brainstorm some of these complex diseases and conditions that really promotes the sharing of knowledge across the different institutions. So on that, I will start the presentation. Hopefully you all see my PowerPoint. If you don't, please let me know. So I will speak today about congenital diaphragmatic hernia and the phenotyping and cardiovascular profile to provide physician management. As a disclosure, I just want to mention that Medtronic, via competitive research grant, provided NIRS monitors and sensors for a study that we're currently recruiting at the MCH. Just for Kids Foundation did provide funds for my lab, and this presentation will involve some comments or discussion of some unapproved or off-label experimental or investigational use of ionotropic PG or pulmonary vasodilators and CDH. So we'll do a brief review of CDH and cardiac function, and we'll try to go over some of the different hemodynamics phenotypes that may be encountered. Although I'm sure that with our panel discussion, we will realize that there are so many different variations and fine-tuning that need to be implemented in the care of these very complex patients, and that the multidisciplinary teams that are put together around the care of these patients really are a source of improvement for the outcomes of these babies. So let's start briefly about CDH. It's usually a disease where there's an association of a herniation of abdominal organs inside the thoracic cavity. And it is thought to contribute to severe pulmonary hypoplasia, abnormal pulmonary vasculature, as well as to some degree cardiac underdevelopment. We know it is a disease that affects both lungs and not just the one ipsilateral to the defect. And there's a thought that there might be some component also of abnormal mesenchymal cell function and migration, which is essential for the development of some of the thoracic as well as abdominal organs, including the diaphragm. If we look at cardiac function, which can be greatly impacted in some situation with CDH, in the normal condition after the postnatal transition physiology, infants enter a phase where they are progressively achieving low pulmonary vascular resistances with concomitant rise in their systemic vascular resistance. We know that the left ventricle and the right ventricle have different anatomical properties, which also confer to them different functional properties. The LV has a tendency to be bullet-shaped in this normal physiological configuration, while the right ventricle has a tendency to be triangular, and they both have different as well as common source embryologically, and they share an interventricular septum. So when you were using echocardiography, which is one of the most common modalities to estimate cardiac performance and getting a sense of the interaction between the ventricles and the two systems, we will be talking today a bit about the right and the left ventricular function, but taking into context that they go hand in hand. So the right ventricle tends to contract longitudinally and has a bit of a systolic function that works like a bellow motion with a peristaltic movement of the inflow towards the outflow tract. And within normal configuration of physiology in the postnatal transition, it is usually expected that the septum bulges towards the RV cavity and that the free wall eventually reaches or gets contracted towards the interventricular septum. This might not be true in the context of high pulmonary vascular resistances or low systemic vascular resistances or combination of both. When we look at how to assess or estimate the systolic function of the right ventricle by echocardiography, some of the metrics that have been commonly used is something called the tricuspid annular plane systolic excursion, which tries to quantify the degree of this longitudinal movement by estimating the motion of the tricuspid valve during systole, as well as the fractional area change, which compares the end diastolic and end systolic area in various views for the right ventricle. These are the common views we will be looking at today in some of the cases we will be describing. This is an apical four-chamber view, where by convention, this is the RV, the RA, the tricuspid valve, the LA, and the left ventricle. And then we have the parasternal short axis, which is the view from on top, where in the typical situation where the RV pressures are lower than the LV pressure, we typically have this round LV and crescentic RV with the interventricular septum that is in between. And we can cut this cross-section either at the level of the mitral valve or lower at the level of the mid-papillary area. And this can provide some assessment of the contractility as well as the relationship between the two ventricles. So if you look at patients with various increase in RV afterload, or sometimes decrease in LV afterload, or combination of both, you can see that the two ventricles will interact differently. And with increasing RV afterload, you can see that we get sometimes even pancaking of this left ventricle compared to the right ventricle. And what I tried to exemplify here is that there is a significant crosstalk between the two systems, and that like a couple, if one is a bad dancer, the other one will fall. And so eventually any patient with significant RV or LV dysfunction will have impairment on the other side of the heart eventually. We'll briefly talk about some measurements using what we call strain. Strain is the absolute percentage of deformation of the myocardium. And so if you think of, for example, starting with a myocardium of 10 centimeter, and at the peak of contraction, you go to 9 centimeter, well, you get an absolute strain of 10%. So we can use the technology of speckle tracking, which tracks the echo density of these images to really track from diastole to systole what's occurring in these different segments. And this provides another way that is less angle dependent to quantify the systolic function of both ventricles. And so to just showcase this, we track from a computer algorithm the pixel from the old to the new location. And we're able with that to quantify the degree of thinning or thickening of this myocardium in the different planes. And this can provide you with measurements of the RV or the LV function. So here, this is an example for the LV, either in the apical views or in the parasternal short axis view, to be able to get some of the properties of systolic contraction. This can also be applied to 3D volumes by echo. So this is a LV 3D view with a focus specifically on the LV for the 4-chamber and the 2-chamber in the newborn in our own population. And we can use speckle tracking in order to have a better sense of the end diastolic dimensions and systolic dimensions and get an estimate of the ejection fraction or as well deformation like here. So we'll go on with some CDH cases and try to input some of these concepts while assessing infants that we may encounter with more critically ill illness. So here, this case one is about a left-sided CDH newborn boy who presented with very early on signs of hypoxic respiratory failure, and rapidly the team had to go on to bring this patient on 100% oxygen supplementation. The gas actually at the time of assessment was showcasing some degree of mild hypercapnia with a pH around 7.28, which is a zone that we typically aim in our protocol to avoid excessive ventilation and prevent as much as possible lung injury. The pre-ductal saturation at assessment was 84% and post-ductal was 52. And as you can see, this baby was already on higher mean airway pressure at 16, but did maintain his systolic blood pressure to a range that was found to be acceptable by the medical team, but an echo was requested to try to decipher a bit the underlying physiology. So this is the first echo image I wanted to showcase. In this image, what we see is the main pulmonary artery. We see the left pulmonary artery, and we see the ductus arteriosus connecting to the aorta. By convention, this color box will indicate direction of blood flow. And by convention, whenever it's blue, it's going away from the probe. So from the pulmonary artery to the aorta. And so in this physiology, we can expect that the pressures in this compartment are higher than the pressures in this compartment, indicating that either the pressure here are too high or the pressure here are too low, or that there's a combination of both. In this particular patient, this is an apical view, which is a bit tilted due to the shifts of the organs in the intrathoracic cavity. And we can see here an RV that looks a bit dilated subjectively and an LV which looks a bit underfilled. And the blue jet indicates that there's some degree of tricuspid regurgitation, which can occur when there's annulus dilatation in the context of increased RV dimensions. And so we can use the opportunity of a small tricuspid regurgitant jet to use the Bernoulli principle that through a narrow jet of fluid, of speed of fluid, we can estimate the gradient of pressure between the two cavities. And we obtain tricuspid regurgitation maximal velocity at the peak of systole of around 5.6 meters per second. And if you put it in the Bernoulli equation, it gives you an RV to RE gradient of 128. Knowing that this patient had systolic blood pressure in the 50s, 60s, it tells us that we're quite suprasystemic in terms of RV pressure in systole. This is a parasternal short axis view of the same patient. And what can we appreciate here is that on top, we have the right ventricle that looked quite dilated, as well as a septum that looked like it was bowing quite significantly to the left ventricular cavity, leading to some degree of LV compression or pancaking. And this is the parasternal long axis where we see that despite the low preload, the actual contractility of the LV looks to some degree preserved with an RVOT that is quite dilated. In this particular patient, the PFO was found to be bidirectional, but mostly right to left. The RV was dilated, compressing the LV. There was a right to left large ductus. And so we concluded that this patient was in acute pulmonary hypertension with some degree of right ventricular failure. So to exemplify the physiology that we believed was occurring in this particular situation, we know that this patient had preductal SATs in the 80%, which may be the reflection of either some degree of lung disease with vacuum mismatch inside the lungs, but we know that our CO2 was adequate for this particular patient. So ventilation seemed to be preserved. But the fact that we had mostly a right to left shunt at the PFO level may bring some deoxygenated blood from the right atrium into the left atrium, possibly because the left atrium is underfilled by the fact that the PVR are high and that there's not a lot of blood flow reaching the lungs. Similarly, the LA being underfilled possibly underfills the LV with low preload, leading to a relatively low output from the LV, which makes that there is some degree of dependency to send some of the blood flow, or at least there is increased blood flow going from the right circulation to the left circulation because the PVR are high and there's some degree of unloading of that right ventricle at this level, which explain the significant pre and postductal differences. So in this particular patient, we decided to start low dose fentanyl for agitation. Was started at 20 ppm, and we decided to add a hydrocortisone at 1 milligram per kilo Q8. In this particular context, the patient dramatically increased pre and postductal saturation, and the FiO2 actually progressively decreased to 30%, which allowed us to slowly decrease our mean airway pressure in this particular patient. We repeated the echo just before repair at day of life 5. And at this point, the ductus seemed to be slightly smaller and was bidirectional, but mostly left or right. And you can see here the M mode through the ductus showing that most of the cardiac cycle is left to right with a brief period that is right to left while still on inhaled nitric oxide. So this case was particularly managed with pulmonary vasodilator. But we need to remember some of the basic principles, which involves appropriateness of ventilation, as well as airway care in these patients, while avoiding hypocapnia to prevent cerebral vasoconstriction, as well as avoid too much lung injury in these patients. Locally, we aim for permissive hypercapnia, with pH around 7.25 to 7 to 30.35. We do start occasionally sedation or analgesia to avoid reactive increase in PVR, while being cognizant of not exposing them too much to excessive sedation or analgesia or opiates. We administer oxygen to aim adequate preductal saturation, which is locally in our protocol 85% and above. And while INO has been studied and shown to improve the outcomes of patients with acute PH or PPHN in term and near-term newborns, I do want to mention that most RCTs have not shown this effect on CDH patients. And we decided locally to introduce hydrocortisone for this particular patient, as there's been some data that it does normalize PDE5 and activity in the pulmonary arterial smooth muscle for some animal models with PPHN. The pediatric pulmonary hypertension guidelines do recommend INO to reduce the need for ECMO in infants with pulmonary hypertension and high oxygenation index while maintaining adequate lung recruitment. And it does mention that some infants may also benefit from PGE for RV failure to unload the RV. In this particular baby, we were happy about the caliber of the PDA and we did not introduce PG. Quick reminder that NO works through the pathway of CGMP on smooth muscle cell to improve vasodilatation, and that the PDE5 also works through a similar pathway. This is the Cochrane review outlining the benefits of INO in the PPHN population. But as you know, while the number were quite small, it did not reach the same values for the CDH subgroup. But there's been increasing data showcasing that some infants with particular phenotype will have response to INO in certain contexts of underlying phenotype. Recently, Dr. No from Stanford did actually review a huge cohort of infants of the CDH study group and did not show any effect of early use of INO. But early use of INO may be taken into the context also that there might be a need for more selective use of INO depending on the exact echo characteristics that are underlying to the physiology. The case number 2 is a left-sided CDH born at term, 38 weeks with postnatal need for intubation and mean airway pressure of 15 at the time of assessment. The baby had an FiO2 of 80% with a PO2 of 35, giving an oxygenation index of 35, which is quite high. And at the time of assessment, the preductal saturation was within the ranges at 89 with quite a drastic difference with the postductal saturation. And at the time, the mean blood pressure was 32 in the postductal area, while the systolic blood pressure was 59 to 65. So these are some of the views of the echo. On assessment, we found that the RV-RA gradient was around 100 millimeters of mercury. So if we assume a right atrial pressure around 5 to 10, which is likely closer to 10 in infants with some degree of RV dysfunction, we have a patient who has suprasystemic pulmonary pressure. At assessment, the PDA looked to us to have some degree of restrictiveness and was bidirectional. And as you can see, the QRS being here, it was right to left in systole with about 30 millimeters of mercury above the systolic blood pressure for the systemic side, for the pulmonary side. Looking at the PFO, our PFO looked actually mostly left to right. And what we had from the cross-sectional view was that we had an infant that looked to have a smaller LV compared to the RV, which may be because of preload, it may be because the interventricular septum is compressing the LV, or it could be inherent to the property of this left ventricle. So we decided to run a 3D echo algorithm, and we estimated the size of this LV at 1.9 cc, which has a Z score of minus 3.5 for this particular patient. And knowing that the PFO was mostly left to right, we were uncomfortable to start INO in this patient. And so the decision was made that in the context of small LV dysfunction with altered output and some degree of pulmonary hypertension with a smaller ductus, we decided to start PGE and a low dose milrinone, knowing that the patient had adequate systemic blood pressure and was having a good urine output because milrinone can be renally accumulated if the kidney is not working well. So in this particular setup, we believe that there was some degree of higher PVR with a bidirectional shunt, but a small PDA. With a small LV and some altered LV function, which we saw here an ejection fraction at 34%, we felt that there was possibly poor systemic output that was dependent on this ductus to both unload the RV and provide systemic output. We also felt that the context of the higher LA pressure could potentially explain the finding of the mostly left to right PFO, which would be explaining to some degree the mechanics of the lung, since if you have high LV and diastolic pressure and high LA pressure, You may also have some component of postcapillary obstruction. And by introducing too much pulmonary vasodilatation, you may run into the trouble of increasing pulmonary edema. So this is in the afternoon after the introduction of the PGE and the low-dose milrinone. This is a parasternal short axis where we see now that the LV looks more round. There is still some degree of dilatation of the RV in cross-sectional view. The function of the RV looked normal subjectively, but was also normal by TAPSE, and the ejection fraction, at least by 2D echo, had normalized. The PFO at that point was still left to right, but the PDA was quite large and bidirectional, as well as unrestrictive. So we know that CDH newborns will often present signs of pulmonary hypertension and respiratory failure, and it's important to better increase our understanding of the granularity of the mechanisms underlying this pulmonary hypertension. And there has been increasing reports of LV hypoplasia and CDH, both by autopsy as well as MRI and fetal studies, right, starting from the fetal life. This is thought to be in terms of intrinsic hypoplasia related to mechanical compression during fetal growth, primary mesenchymal defect resulting in some degree of left-sided anomalies, as well as maybe some degree of abnormal streaming of fetal blood flow, preferentially filling the RV during fetal life. But there also may be an important contributor in the postnatal setting when there is low pulmonary blood flow causing low preload to the left ventricle. So here we have some of the references of different studies looking at LV and CDH, both at the fetal, newborn, and adult level. We did review the cohort of Stanford when I was there with Dr. Bombal, and we found that infants with poor LV function by strain were the ones that were more at risk of undergoing eventually ECMO. And this finding has been reproduced in different cohorts, such as the one of Dr. Patel and Dr. Kitzmiller and Dr. Masolo, who have been doing a lot of work on this population. As you may know, there is currently an undergoing randomized control pilot trial looking at milrinone as a potential agent to potentially address DLV. The milrinone is a PDE3 inhibitor, which increases intracellular calcium. And the theoretical effect of this drug is that it may have some degree of lusitropic properties, promoting the filling of both the LV and the RV. But we know also that it may decrease systemic and pulmonary vascular resistances, leading to decreased afterload of both ventricle in the context of underlying dysfunction. There is very limited neonatal data, so we're all looking forward the publication of the results from Dr. Satyan of the milrinone study of the NRN. And as a, I want people to remember that it is renally excreted and can accumulate in blood. And so in patients with already hypotension or in the context of renal dysfunction, it may not be the best agent to choose. PG have been described in the use of patients with refractory and circulatory dysfunction of CDH, and it's been described as improving oxygenation in some of these infants. And it's especially of interest if you have some degree of biventricular dysfunction, but obviously we need more data and experience and expertise on the subject of this use, indication and duration. The case number 3 is a 38-weeker male with a prenatal diagnosis of left-sided CDH. The infant was known to have the liver, the spleen, and the chest, and was initially mechanically ventilated initially volume guarantee and was switched to pressure control 25/5 times 45. Initially, the patient was on 50% FiO2 with pre and post differences. Preductally, the patient was saturating at 95, which is quite different from the other previous cases. And postductally, the patient was saturating at 75%. The patient was started on INO overnight. And by the time we were called for evaluation, the blood pressure had been maintained at 57/41. This is the echo that we obtain on assessment. And what we can see here is a 2-chamber view of the LV and the LA. a view with colored boxes over both the tricuspid and mitral valve that are showcasing some degree of mitral regurgitation, which is an element that we can see when the ventricles have struggled because the papillary muscles are watershed area for the heart. And whenever there's endocardial ischemia or dysfunction, mitral valve and tricuspid valve could showcase some degree of regurgitation. And what we saw here was we appreciated some degree of dyskinesis of both the septum and the lateral wall of the LV. So we did run some of the speckle tracking strain algorithm, and what we saw was that there is a marked dysfunction of the left ventricle, which can be showcased with an estimated ejection fraction based on the speckle tracking at 21%. So in this patient, we diagnosed moderate to severe LV dysfunction. At the time, the patient had adequate lactate in the range of 2 to 3 with a urine output of 2 cc per kilo per hour. INO was weaned, and there was a decision to actually initiate milrinone, to which we added a low-dose epinephrine. Considering that there was normal blood pressure and urine output, this patient was kept on 0.5 mics per kilo per minute with hydrocortisone. The echo was repeated on day of life 3, which showed mild to normal LV function by ejection fraction, a PDA that was small and bidirectional, but mostly left to right. This patient underwent repair at day of life 4, and we repeated an echo at day of life 6. So in this echo at day of life 6, what we see here is a short axis view, where again, we appreciate some degree of RV dilatation and bowing of the septum into the LV cavity and systole. The RV 3D view did showcase that in the anterior posterior view, we had some marked degree of RV dilatation. And when looking at the PDA profile, which was small and restrictive, it was bidirectional with 33 millimeters of mercury at peak of systole above the systolic systemic pressure, indicating that this patient was in a situation of suprasystemic pulmonary hypertension. When we look at the RV specifically, at the time of the echo, we had an RV-RA of 94, so suprasystemic, and the PFO was mostly right to left. So in this context, we decided to start INO while during the echo assessment, and these are the views at 5 minutes after the start of INO. And what we can see here is that the RV looks subjectively less dilated and the TAPSE had normalized. The PDA is still small and restrictive, but at this point it had converted to be mostly left to right, and the TR had dropped to be 50, which was more in the isosystemic range. So with that, we were happy with our INO, which was started at 20. And then in this context, we felt that this patient was showcasing a mixed picture of initially an LV dysfunction that eventually developed in a reactive pulmonary vascular disease in the post-operative setting. So we reattempted INO wean a few times. Actually, we're quite aggressive at trying to wean the INO in the days following the introduction. And despite that, we already always did INO wean during echo guidance. And we finally had to transition this patient to sildenafil. The last echo, which was done at 3 weeks of life, did show a TR of 37, and the RV function and LV function had normalized by various metrics. I will finish quickly this talk by a fourth case that is still undergoing. This is a 26-weeker male, which was born after premature rupture of membrane at 24 weeks. It was a right-sided CDH that was postnatally diagnosed, initially on X-ray. When this baby was born, he was intubated in the delivery room due to respiratory distress and rapidly went to 100% oxygen. The right CDH was noted on first X-ray and was confirmed by ultrasound to make sure that this was not an eventration. Initially, we started volume guarantee ventilation, but rapidly the patient was switched to the jet ventilation with a mean around 11. And because of the high oxygen needs, despite the appropriate CO2 parameters and a significant pre-post difference, the decision was made to do an echo on the first day. At that time, the blood pressure were within the ranges for this infant. So the first thing we did was to make sure this patient did not have a coarctation. And I want to mention this because we know that some babies with CDH are more at risk of having congenital heart defect. And so as such, these babies should be discussed with colleagues in cardiology to make sure that there's no underlying congenital heart defect, because they're at risk of coarctation, they're at risk of hypoplastic left heart syndrome, as well as other types of CHDs. Here we have again the PDA view, which shows the RPA, LPA, and the PDA, which was large and unrestricted, and completely right to left. We can see here the pulse wave Doppler, which shows that there's relatively unrestrictedness in terms of the blood flow growing from the pulmonary artery to the aorta. The PFO was mostly right to left also. So I did a little freeze because we see a lot of the SVC, and this is a tilted view of the subcostal, considering the right-sided CDH. But you can see that here we have blue flow from the RA to the LA, introducing hypoxic blood into the systemic circulation via the atrial level. The TAPC was mildly decreased, which is an RV functional metric, but our fractional error change was preserved. The LV function looked preserved, and we did run an ejection fraction, both by two chamber and four chamber for the biplane Simpsons, which was within normal limit at 55%. We did do some of the TDIs because we were well angulated, but as you know, we always have to be careful with tissue Doppler, looking at the velocity of the movements of myocardium because it can be quite angle dependent. And in that situation, we found that there was some decrease of the RV systolic velocity based on some of the normal values for preterm cohorts, and a relatively normal range for the septal value of the LV. So this patient, in this context, it was decided to start INO, and because there is controversy about INO and the risk of steal from the systemic circulation with a rapid drop of pulmonary vascular resistance, especially in immature babies, we decided to do serial monitoring in this patient to make sure that there would not be a very rapid reversal of the shunt. So we titrated the INO to 10 ppm in this patient, as premature babies can be sometimes exquisitely sensitive to the medication. And here you can see an M-mode color through the PDA, and you can see that it's bidirectional, but mostly left to right throughout the cardiac cycle, and briefly right to left in systole, with a ductus that looks at least moderate in size. Here you have the flow pattern velocity via Doppler, showcasing that the velocity are quite low. This patient was then re-imaged at 48 hours of life with the INO that was weaned at 5 ppm. And what you can see here is that the RV function had completely normalized by TAPC, and that the LV function looked again preserved. And at this point, the PDA was mostly left to right, again with low velocity. And there was no IVH in this patient, and this patient had multiple head ultrasounds that did not showcase IVH. So this patient is still, we tried weaning a few times the INO, and it's very reactive to the INO in this context. So in summary, I want to briefly show a beautiful slide that Dr. Bombal and Dr. Satyan have put together in order to exemplify some of these physiology and phenotype that might be seen. And what I want to mention is that these babies may change over the course of their hospitalization, and that's why I think it's important to address these patients in a multidisciplinary fashion and do punctual evaluations at times where it is felt that it will bring some important knowledge in the management of these patients. So we all have seen the CDH infants with postnatal adequate transition, but that obviously do require exemplary respiratory care. And often these infants will not require as much FiO2 needs and will have typically no important differential of saturations because they're shunting left to right at their atrial level as well as their PDA level with good pre-ductal saturation, good post-ductal saturation. The pre-ductal saturation being dependent on both the pulmonary venous saturation and the lung integrity, as well as the degree of shunting at the atrial level. We've seen also the patients that have some degree of acute pulmonary hypertension phenotype, and many of which seem to respond to some degree to the pulmonary vasodilators. But what I think I want to reinforce is that pulmonary vasodilators can have different effects, and because of the changing physiology, we also have to be careful and titrate eventually the medication using the information we can get at bedside and based on echocardiography. So typically these infants have more right to left shunt at the atrial level, as well as a right to left shunt at the ductal level, with more RV pressure overload and a tendency to have a bowing septum that can impair the LV cavity. The third phenotype, and sometimes there might be a mixed picture, is infants that might have a high contribution of LV dysfunction. And we saw that in our third case that was presented here. And these patients may have high LV and diastolic pressure, which can be reflected into the left atrium, leading to more pronounced left to right shunt at the atrial level. So based on these different phenotypes, you may consider different treatment strategies. Obviously, I welcome a lot of our experts on this table to continue doing the great research that they do, because we need more and more data on this orphan disease to try to better characterize the best treatment approaches based on these different phenotypes. But as per the current knowledge that we have on the effect of some of these medications, we know that when you fall into an area where you have moderate to severe high increased pulmonary arterial pressure, in the context of these different phenotypes, you may introduce medications that you have to titrate very carefully based on the end outcomes that you're trying to obtain. So we can think about patients with RV dysfunction and some degree of acute pulmonary hypertension, which may benefit from INO, but also may benefit from maintaining their ductus open. We know that epinephrine can be an agent that will support inotropy, as well as like dobutamine that may also promote LV function and RV function, and milrinone, which can be used under special circumstances, and for which we're waiting more data coming upon soon with the RCT of Dr. Satyan. So I really want to thank the organizing committee, and I really look forward for the discussion with the panelists. And I welcome everyone to try to consult the website NeoCardiolab if you have time, as there are many resources, and I welcome any comments and questions. Thank you.
Dr. Altit, thank you so much for a really fantastic talk. That time went by really, really quickly, and I wish you actually had another half hour to delve into additional detail. But so thank you so much. We do have already a building list of questions. I want to remind everyone to please put your questions in the Q&A box, and we will certainly get to them in sequence. Again, apologies if we don't answer your specific question. If not, as Dr. Ross mentioned, will be answered, I think, on the Twitter account. But I did have one question for Gabriel, as you really so eloquently described how we're really into the era of using our hemodynamic assessment for precision management of these babies who have clearly different cardiovascular phenotypes. I guess one of the questions that comes up is, and you showed, I think you showed cases that are perhaps fit a bit more neatly in some of those boxes, but there are other cases where things don't kind of settle along those lines. Could you describe a little bit more? So in your previous work, you've identified that differences in ventricular function, both LV and RV, as well as RV and LV morphology, specifically even LV morphology, as you pointed out in case 2, that those are, you've shown differences relative to controls, to healthy term babies, as well as to that they also relate to clinical outcomes. For the babies who are on the borderline, could you help our audience? How do you guide the babies where those structural and functional, morphological and functional differences are on the borderline? How do you navigate those even more difficult cases?
I think that's such an excellent question. I cannot wait the panelists to also join in in that question. I think it depends what you are able, like, what is your perceived primary mechanism that is underlying the clinical presentation of your patients, because we've seen patients who have smaller or borderline LV, that obviously it's very hard to, separate, okay, well, what's intrinsically hypoplasia of the LV and what's intrinsically a degree of underfilling. And there's the other layer of complexity where some of these LV, which are maybe underfilled, so obviously assessment of the output and cardiac function in terms of their contractility may be a bit more challenging to completely discriminate, especially if there is MR. So if you have significant MR, you can unload into your LA, and so it's easier to unload in your LA than in your systemic circulation. So I think for personally, when I assess these patients, I try to get a sense, well, what do I think the LV size is primarily? Do I feel like it's a small LV filling or restricted filling or issue with the filling? Do I think that there's a component of primarily LV contractility defect, and we really think that the function is impaired, and so I need to support the function, or is there a mix of both? And as you know, the inotropes or the medications or strategies that we use, they're all limited by, the knowledge and data that we have. But in a situation where I think filling is primarily impaired and I want to promote this filling, I think that milrinone might be an option to consider, because we know that there is some data that it improves filling in some of these patients. While if it is primarily a contractility defect, which I think I exemplified in one of the cases where the ejection fraction was 21%, I think they need some degree of, kind of inotropic medication that can support their LV while they're transitioning. So we can think about, low dose epinephrine or dobutamine, or sometimes even PGE if the PDA is very small, because you're in a situation where you need to sustain output and the RV may help you with that. So I'm not sure I'm totally answering your question, but I think that when you're assessing these patients, it's almost like you need to do your little boxes and write all your assessments and say, like, what I think is happening with my RV, what do I think is happening with my PVR, what is happening at my ductal level, what is happening at my PFO level, and then what's happening to the lungs, and how does my baby look like, right? We have seen patients that look actually pretty good on clinically, and then we do the echo, and they do have some degree of RV suprasystemic pressure, not double the amount, but sometimes we do have a mild increase in RV pressure, and we'll just observe, because the LV function is adequate, the RV function is adequate, and we'll just observe and do a repeated echo and see how the baby does. But I think, as you mentioned, there's a lot of precision medicine that I think comes into the play of these patients, the same way you would do a lot of precision medicine in like a post-op cardiac condition, where I think some of us deal with some of these patients, and sometimes you do have to adjust based on what you think is the preload issue or afterload issues. But I would love to hear what the rest of the panel thinks on that.
Yeah, Dr. Fraga, what in your experience with you see quite a volume of CDH at CHOP. What kind of phenotypes do you typically see, and is there a way to predict phenotypes when these kids come out of the DR, as you often do get them?
Yeah, thank you, Shazia. Yeah, as you know, we do have a big number of CDHs a year here at CHOP, and I personally have been treating these patients for many, many years. So I think that the first thing I'm going to say is that over this time, I have become more and more humble when treating these patients, and because I have been fooled by them so many times. So meaning that what I want to say is that it is very hard to frame this patient under a phenotype. And the reason why is because, the cardiovascular physiology changes so quickly within the first hours or first 2 days of life, that if we get stuck with, LV dysfunctional phenotype, then more likely in 2 hours, you're going to be totally wrong on your, targeting treatment. And especially you have to just reassess all the time and be open to different alternatives. So as you know, like traditionally, I think we used to think about CDH with, abnormal pulmonary vascular and pulmonary hypoplasia, increased PVR, RV dysfunction. But I think that many, many years ago, we started to have some clues about what was happening. So 1997, when the NINOS trial came out, already was saying, infants with CDH that went on nitric, they are actually more likely to need ECMO. So what's going on there? So luckily, then cardiac function, I think, has been looked at more closely in the recent years, and mainly due to Neil Patel, who actually has published so much on this. So we really got to understand that, you know, the RV doesn't just stand alone, and we have to really look at and integrate what is happening with the left side of the heart. And as Gabriel said, you know, the right and left fibers are pretty much interdependent, and that's the interventricular dependence. So meaning that a dysfunctional RV will affect adversely the left ventricle, right? And what is more, as Gabriel already mentioned, these infants with CDH are also born with some degree of LV hypoplasia. You know, like it could be like borderline hypoplastic left heart. Yes, you know, we know that 15% of babies with CDH do have congenital heart disease. So we have to look into that. Or it could just be LV hypoplasia, call it due to compression of the LV in utero or reduced LV blood flow, whatever. But this LV hypoplasia will contribute with, you know, LV dysfunction as well. And as a result, as you know, there's going to be a mix of this like picture, like RV dysfunction, LV dysfunction will lead to decreased stroke volume, systemic hypotension. And this is perpetrating what we call, you know, the vicious cycle of the CDH with a metabolic acidosis, hypoxemia, systemic hypotension. So is it important to recognize the phenotypes? Yes. Will it change constantly? Yes. But if we have a clearly, you know, LV dysfunction phenotype, I think it is very important because we have to be very cautious about what treatment we start. And we've seen that many babies that we put them on nitric with LV dysfunction just do very poorly and they go on ECMO, right? Here at CHOP, we just published a couple of years ago our cohort, and all the babies that were not respondent to nitric, they were all babies with LV dysfunction, right? So very important to be cautious about that, and also very important to identify this phenotype because you will be cautious about using any pressor that will increase the afterload, right? If you have an LV dysfunctional. So if you are lucky enough to practice in a center, not like CHOP, but you can use open label milrinone, then you would use that. But here at CHOP, we are enrolling babies under Satyan's trial. So at the moment, we're not really using open label milrinone, only under the trial. So anyways, I think the main message is this constant reassessment and understand that this keeps changing all the time. Sorry,
Thank you,
Okay,
Dr.
I want to ask, can I ask a question?
You can,
Sorry, can I? Yes, you hear me? Okay.
Yeah.
Yeah, you know what I've noticed, like that's just like anecdotal, so totally non-science, okay? But I've noticed that many of our babies that end up eventually postnatally with, you know, LV dysfunction or LV concern actually were tagged already prenatally by our expert fetal cardiologist saying, watch out, there might be a coarct, or watch out, this LV is small. And in some of these babies, we actually are quite rapid at starting PGE, and many of them have done like a kind of a smooth course. And then eventually they get off, you know, they get operated, they get their follow-up, and they don't have a coarct, and they don't have like small, it's like almost the LV is able to some degree recover from some of this process, although there's emerging data, at least from MRIs in adults, that shows that maybe they still have small LVs in these patients. But I wonder what the experience in other centers, like have you seen some of these cases which were tagged prenatally as maybe coarct or maybe LV hypoplasia, or that's not been something that you've seen?
I share your comment 100%. We do see here like more and more often. So prenatal echoes, big concerns for coarctation, and these babies go on prostaglandins right after birth, and then like almost none of them have coarctation. But they really do have a really hard time like evaluating that arch, and there is always narrowing of the isthmus, and there's always that concern.
Thank you, guys. I think for Dr. Kipfmiller, I want to bring this question to you. If you could address how prenatal echocardiography might help in risk stratification for these babies, and specifically addressing one of the questions from the audience was, can prenatal echo help us with this, with the CDH cardiac phenotyping? And my personal question, having read your work, was, I know it wasn't discussed today, but what's the role of cardiac biomarkers in our assessment and evaluation and management of some of these kids.
Yeah, thank you. Thank you all for your previous comments. I totally agree that it's a very crucial element of prenatal assessment that you have a look on the cardiac function, or specifically on the LV. And we share the same experience from CHOP, that we have quite a large proportion of kids who were referred with presumable coarctation, and many of those kids have none. Actually, the majority of kids with CDH and coarctation are those who are prenatally not detected and come through the door from a different hospital. So I think that's important. For the proportion of the phenotypes, we have recently analyzed a subset of our CDH patients, about 190 kids included, and we can see that about 40% have a phenotype in the first hours postnatally that fits into the small LV, large RV pattern, and only very little with a really dysfunctional enlarged LV. This is about 5%. The rest pretty much look normal, and with normal I include those who had isolated RV dysfunction, because we know also from the trial that we have published a couple of years in the Blue Journal, that isolated RV dysfunction is not a key driver to mortality. It harms a little bit the patient. We have to deal with it. It's important to look at the kids, to start medication, start some amiodarone or dobutamine, but it does not really kill the patient. Well, the LV dysfunction and the poor LV structure as well, the small LV, it can really be difficult in the long term. And for your second question, the role of cardiac biomarkers. So we have investigated quite several biomarkers. Most of it is anti-proBNP, which is very common to use in Europe, which is kind of similar to the BNP, but have a longer half-life, so the kinetics are a little bit different. And personally, I would say it has a role, and very high. We see very high anti-proBNP values in kids who proceed to ECMO pretty early during the course. And especially also when we look on the ECMO patient, we have published this. One of our residents, Bartolomeo Bo, has published this last year in the Journal of Pediatrics. We can see in those kids who do not demonstrate a drop in the proBNP during the course of ECMO, they do specifically worse, and we can also confirm this by echocardiography. So I think there is quite a role for this to assess kids during ECMO. Personally, I have to say I'm dealing with CDH kids for probably the last 11 years. And the more I deal with these kids, the more I rely on my feelings and not really on markers. So because I share Mackie's feeling that they have tricked me so often, and I turned around and they are like my kids. They really do what they want when I don't look at them. And it is quite difficult, so there are some other biomarkers we have investigated. Soluble ST2, which is not commercially available, but what is has been tested in large adult studies, which really shows a really surprisingly good correlation with the cardiac dysfunction. So I would say there might be a role for soluble ST2 in the future, but we have to confirm our results in a larger cohort, and we have to wait until it's like really available in most of the labs.
Thank you. And Dr. Jane, I want to give you an opportunity to comment on that, and also to ask, as you talked about these different phenotypes and the kids can change all the time. When do you initially do echoes on this population, and how often do you do them? Do you do them after changes? Do you just check on them intermittently? We've had a couple of questions on that from the audience.
Thanks. Yeah. First of all, it was an excellent presentation, Gabriel. It was very interesting cases. My experience of CDH is very limited, so I'm going to be disappointing everybody here, because I work in a center where CDHs are born, stabilized, and after the first couple of hours, transferred to the PICU in our center, where in a different hospital. So I don't necessarily actually have a lot of experience of directly managing them beyond the first couple of hours of life. And even that sometimes is too hard, I think. But in terms of the phenotypes of PPHN, as Gabriel mentioned, I was sort of thinking on the same lines as the other panelists have already said, that presetting yourself to the phenotype that you're observing too early in postnatal life, to me, is a recipe for disaster, because there's just so many things happening at that time that to be, and my experience with PPHN, just in PPHN, actually is the same. That if you think this is a particular phenotype, but you've already decided that this patient is falling under, a few hours later, it might be completely different. I would say, though, one thing, I'm very intrigued by the LV dysfunction debate in CDH, and I've been reading papers about that for the last few years, because in a non-CDH PPHN population, I don't see that much exclusive LV dysfunction without RV dysfunction and being the primary predominant. So I think that's a very unique thing that's that people who have observed and studied CDH seems to come across. And I think, as Lauren was saying, it's not a large proportion of the phenotype, but a small proportion of the phenotype, which is probably important to recognize. But how does the AS, and the other thing I find quite intriguing, and again, I've been reading about this for quite some time, including from you, Shazia, is the ASD and PDA flow interpretation and how that might determine the management. And I'm always intrigued by that because again, that experience has not panned out in a non-CDH PPHN population that I tend to look after, including the HIE ones. And I wonder what your take is in terms of the ASD flow being left to right in certain PPHN population where you expect the right pressures to be high. Is it the LA pressures are too high in the presence of elevated RA pressures, or is it that the RA pressures are not that high compared to other cases? Because the ASD flow depends upon the RV compliance and are not necessarily always based on poor LV compliance, which is what I think you were interpreting, Gabriel, right? How do you distinguish the two?
It's tough also, right? But, when we see that there's predominantly, for example, a right to left or predominantly bidirectional right to left PFO, we do look at other metrics. So we see like the degree of RV dilatation, the degree of TR jet, like how much there is in terms of tricuspid regurgitation. We looked at our subhepatic veins, IVC, to make sure that there's not too, like we look, is there a dilatory effect on the subhepatic veins and IVC. And sometimes it's difficult to completely discriminate. When we see that there is completely left or right PFO shunt at the context of PDA, I think, we also try to put it in the context of the clinical picture. If we see that the patient is presenting clinical signs of PPHN with, significant preductal desaturation, where's this preductal desaturation coming from? If the LA is completely decompressing into the RA. So then it means it's mostly lung disease, right? So then you have to really look at your lungs. How is your VQ mismatch? How's your ventilation? How are your parameters? Do you have atelectasis, airway secretion, things like that? Versus if you have bidirectional shunt and you do have a good, air expansion on your X-ray and good auscultation and good CO2 clearance, and at this point, you have a bidirectional shunt at your PFO and a very profound desaturated preductal saturation, then, it most likely is that this hypoxic blood is entering from the atrial level. So then that you're mostly likely in a PPHN physiology. I think one of the cases that I showed which was a predominant LV dysfunction with pre and post differences and with a right to left PDA shunt was a left to right atrial shunt with 95% of saturation. So at that point, my lung seems to be doing adequate clearance. I seem to have, a left to right shunt at my PFO. I do have pre and post ductal differences, but I think what was the main contributor at this point was LV dysfunction. But yeah, sometimes it's very difficult to completely discriminate and departate because you can have mixed physiologies. I think Maki outlined very nicely, that some of these babies may react differently based on the treatment that you put in, and then they change their physiology. You've addressed the LV dysfunction, and suddenly they end up with some degree of PVR increase, and then you have to look into that and then modulate your therapies. And that's why I think multimodal treatment approaches to these patients is so important, and looking at the bigger picture of the overall treatment. I think there was one question about sedation. That's part of the equation, but I don't necessarily advocate for aggressive sedation in all these patients. I think it has to be also introduced on a case-by-case basis.
Yeah, sorry. Now going back to the question from someone from the audience about when do we do echocardiograms on these patients? So at least here at CHOP, I'm going to just speak from my experience. So we actually did come up with a shortened version of an echo for the first day of life in those babies who are severely hemodynamically unstable. So definitely they will have a first echo within the first 24 hours of life. Initially, we wait a couple of hours until we can establish adequate lung recruitment, which takes a little bit of, a couple of hours until you can open up the contralateral lung. Once we are happy with our lung recruitment, then the baby will have an echo. But as I said, if the baby is unstable, we do a focus echo done by cardiology. And we looked at, function, PDA, PFO. And we decide there if we want to start prostaglandins or not, what kind of treatment we're going to do. And for that echo, we actually do give extra sedation to these patients because we've seen them decompensate so quickly after, long echoes, and even go on ECMO after a long echo. So we always have a frontline clinician at the bedside doing the sedation. And sometimes if they are very unstable, we even do a paralytic for that. We do deal with very, very sick CDHs, and that's why we came up with this protocol. Otherwise, if the baby is stable, they will have a full echocardiogram within the first day of life.
Thank you, Dr. Freck. I did want to tap into Dr. McNamara, the experience at Iowa about the babies with CDH, and how you guys with your T&E team incorporate use of echo for these borderline cases where I'm really not sure the degree of pulmonary venous hypertension versus just the contribution of pulmonary vascular resistance.
But before I say anything, I want to latch on to Maki's last comment, which makes me very happy. We've never seen this. We've never seen a baby get sick when a neonatologist performs these echoes. That might be something of importance here. I think it's something to definitely think about, and we take care of really, really sick babies as well. I just want to comment on a few things, which this has been a phenomenal discussion. And I think probably the wisest comment made so far actually also was from Maki, which is these are incredibly complex and dynamic patients. And I think the concept that a phenotype is static in this physiology probably doesn't make a lot of sense. The one thing that I think is particularly interesting, I think is a gap in the literature, is we actually don't have echo-naive research, meaning our treatment-naive research. Most of the work that's published are on patients who oftentimes have already received treatment. Mm-hmm. What is that ground zero status on the patient before you've given them nitric, before you've started a vasopressor, before you started an inotrope? What's the starting point? And I think, it gets to the whole question, like if you have a left heart phenotype and you don't treat it well, I think we're naive to think that you just sit having pulmonary venous hypertension and you never can get a pulmonary arterial component. Those patients will get secondary pulmonary arterial disease. Like we see that in some of these babies with profound LV dysfunction that present in a non-CDH setting. So I think, being open-minded to constantly reassess the patient, constantly reassessing the treatment that you do, I think is important to better understand, the physiologies. Rightly or wrongly, where we do an echo before and try to select very thoughtfully our patients who we give nitric oxide, we have a response rate that's close to 80%. So a lot of our babies seem to respond to nitric oxide. And we will eliminate out those babies that do have a left to right atrial shunt. Although we don't see a lot of them, honestly, from the treatment naive, group. There are some, and absolutely, we see the babies with a small aortic arch, and we will not give them nitric oxide. But they're not a huge percentage, which makes me wonder, are there some babies that give the appearance of a left heart phenotype because of ventricular-ventricular interaction? That if you have a very dilated pressure-loaded right heart and maybe you're on the wrong drugs, the left heart can also look a little bit small. So I think it's probably not just a simple, there is one answer or two answers to this patient population. My last comment, I'm going to go back to the group, which I think is something that I would love to hear from the other panels. Our experience of the small left arch is when you fix the patient surgically and get rid of the mass in the mediastinum, that the aorta starts to look more normal looking. So how much of that could be mechanical because of that pressure loading effect of the mass of bowel and whatever else in the chest compounded by mechanical ventilation? So those are my
Patrick, I have a question. So what's your criteria for nitric response? What do you use there at Iowa? And then the other question is, don't you usually see patients that do respond initially and within 2 hours, they do not anymore?
Not an awful lot. There are some. There are definitely some. And those babies that do that become, say, INO refractory or INO relapsing, appear to have a progressive pulmonary arterial phenotype that we, continue to, I've not seen that those babies that respond, then suddenly we're dealing with a big left-right atrial shunt and an LV that's not looking well. They do seem to be, the subpopulation that just have the worst of the worst pulmonary vascular disease or extremely small lungs. And invariably, those, at least in our experience here, those are the ones that go on to ECMO, but we've very, very low ECMO rate. It's not a lot, but we don't see as many as you, Maki. You see a lot more patients, and that's why your perspective is incredibly important here. But, I just wonder how much of the battles do we lose because maybe we just don't get the right information early enough to find out what's our starting point. Because if you're already on a bunch of drugs and treatments, your echo, as we've all have said, it's incredibly dynamic. It changes fairly rapidly, and not just when they are, off ECMO, when they go on ECMO, you see all sorts of craziness happen too as well with, particularly those who have an open duct. So it's a complicated patient population, and I all I can say is I really, really worry about the current thinking that nitric oxide is a bad therapy in CDH. I think there are patients that benefit, but there are studies. There's a trial to be conducted called the No trial, which is very much designed to show it is an unsafe therapy in CDH. And certainly, in our experience, we've had many babies who responded well and do well. But there are absolutely some that may exactly have what you say, Maki. We've seen them, they respond initially, they continue to get worse, but I've not seen those as the left heart type babies. Those babies, we've given some milrinone, we don't give them nitric oxide, and they tend to go down a different path.
Dr. Kipfman, I would love to hear your take on this.
So I want to comment on the question about the arc and the situation of the arc. So I had the feeling always when the arc looks pretty small in the beginning, that in most patients it improves a lot even before surgery. So I think they have a higher rate to go on ECMO, because it is combined very often with a small LV. So these kids might end up on ECMO, but during the ECMO, the aortic arch improves quite well. And we do not do surgical repair during ECMO in our institution, so only as a rescue therapy, what I think is not a good idea, but that's our philosophy. And usually the vast majority is repaired after ECMO. And most of those kids have a substantial increase in both the LV and also the aortic arch. So I think it's not just mechanical compression.
Thank you, Florian. Gabriel, I'll give you some last comments. I see your hands raised.
Yeah, I don't know how much time we have left, but this discussion is super interesting, and it could go on for like 6 hours, probably 10 days, even more. So I'm looking forward for the next CDH symposium at some point so we can continue on going with that. But I think a few comments I wanted to do. I so agree with everything that was said, which is that they're very dynamic. I think Dr. McNamara alluded to the aspect that they change a lot in the post-op setting. And I think I'm sure Maki and Florian can add on to that. But we've seen, and I think one of the cases that I presented had like very drastic different physiology in the pre and the post-op settings. And I think part of it is probably the operative stress and the inflammation that is related to that. Part of it might be some changes in like preload and compression. But definitely, I think there's, I would say, a lack of, I guess, research in what's happening in that post-op phase, because it's super important to prepare them in the preoperative context, but it's also important to support them in the post-op context. I've seen cases actually that were started blindly on INO, and I suspect that there was an underlying LV kind of phenotype that ended up with pulmonary hemorrhages. So I don't know if it's something that you've seen in your practice, but I also seen patients with excessive drastic response to INO, like immediate response that lasted. And so I do believe that, these babies have different reactions and it's why it's so important to get the information and knowledge when we assess these patients, because I think that some of these babies do respond to INO clinically, but that's just a biased comment from myself. And I would love to hear, if we have time, if people can comment on the effect of fetal in this population in the hemodynamics, but I know we're very short on time.
We do not have a lot of data yet, so I don't know if we can really comment on that. All I can say is that so far we've seen that those babies that had the fetal intervention require less ECMO. This, so far, what I can say. What?
I was just going to ask Shazia or Danny if you could ask the panelists who uses empiric hydrocortisone, because I thought there were a lot of questions on that on the chat as a key intervention strategy. So is everybody using that for all CDHs, that they're giving it prophylactically, or they're just? No,
we have done this for a couple of years in the early 2010s or so, 2011 till 2014. We used it quite often and quite early on, but then we switched it. It's coming back a little bit. We measure early on the cortisol levels, which are usually low in these kids. So there might be a need. I think it's an important point to keep the hypothesis in mind that it might improve the PDE5 activity, so I think it is a good. I think it's important to have something inotropic and vasopressor early on in your therapy. We started, for example, and I want to give this as a discussion, we start almost every CDH patient on prophylactic minorenone, even in a little dose. We do this for all these, the PDA closure kits, and for some cardiac surgery kits to prevent low cardiac output syndrome and or post PDA closure syndrome. And we see a much better left ventricular function. So we cannot, we did not reduce the rate of kids with a small left ventricle, but the function itself looks quite a little better. And I have the feeling that the left ventricle, when stimulated with minorenone, is quite more or can better handle INO or sildenafil, but that's just my personal feeling.
Here at CHOP, we do use a lot of hydrocortisone very early, not prophylactically. So of course, as Florian said, we do start an inotrope. We have been using lately, a lot of very low dose epi, low dose 0.01, 0.02, and really early hydrocortisone with systemic hypotension.
We have a similar approach than what Dr. Fraga mentioned, like not at large, all of them, but very selectively.
Well, thank you all for this. We could talk for, as Gabriel said, hours and days on this topic, but thank you all for participating in this talk. And Gabriel, thank you so much for your excellent presentation and for this discussion. I'm sure this will not be the last time that we have conversations on CDH, but thank you all for being here for today. This talk will be available on recording on YouTube, so we'll send that information out. Thank you so much for attending.
Thank you, everyone.
Thank you, everyone. Thank you for organizing this.
Fantastic job, guys. Brilliant, all of you.
Thank you.